So, gonna go and get started. I have a confession to make. I love hyponatremia. It's weird. It's almost a sickness, really. I wake up thinking about it, go to sleep thinking about it. I'm not allowed to talk about it at home, so it's a sickness. So my goal for this talk really is I just want one person to come to me and say, Sharad, I didn't like hyponatremia before, but I kind of like it now. But that's all, right? Even if you're lying to me, one person, please ask me. So to tie in portal vein and hyponatremia, to really understand why I'm trying to make that connection is I have to go back to my nephrology fellowship. So I chose my fellowship because my mentor was a sodium specialist. I always found hyponatremia fascinating, at least on a theory level, right? The equations are there, they're great. You know, it's clean, you know, it's physics, it's chemistry, but in practice, it never worked out that way. Have you seen that? It's just in practice, it just doesn't work out that way, right? So I was in search of a more precise way to treat hyponatremia. So I started reviewing the literature. I was starting to learn ultrasound a little bit, and there really wasn't much out there about renal dysfunction and ultrasound at the time. I read a paper about venous congestion and increased probability of AKI. This is a bad dream I had where I'm doing a presentation, my slides wouldn't come up. So luckily, Haney's here to the rescue. All right, thanks, Haney. So I read a paper correlating venous congestion and AKI. And I started to pay attention to the venous side. Like, this is fascinating. I always thought in cardiorenal syndrome, AKI, renal dysfunction, it's the output. But I really started to pay attention a little bit more to the venous side. And then I came across a paper that talked about portal vein pulsatility. And I was wondering, what is this? And it found a correlation by Dr. Deneau and William here. And they found a correlation when the portal vein is pulsatile. So the vein is normally not pulsatile. When the portal vein is pulsatile, it correlates with AKI and likely is a sign of venous congestion and organ congestion. So I thought, wow, this might be something. I need to go and learn this. So I came last year and I learned the technique. And I've been using it since. So I wanted to see if it predicts AKI. In my head, hyponatremia is just part of that spectrum. So let me convince you of that. So if you, so this is the spectrum that I think about when I'm thinking about venous congestion and AKI. So you start off with the insults. You have a low cardiac output state. There's venous congestion. Your body interprets this very similarly if you just had a purely low cardiac output state. The baroreceptors are going crazy, increased sympathetic innervation, and you have a high RAS and ADH state. So in hyponatremia, ADH gets all the attention. RAS is just as important. So renin, angiotensin, and aldosterone. So what does that do? So when you have venous congestion in cardiorenal physiology, you reabsorb all of your sodium in the proximal tubule. So you remember the segments of the nephron. I found in past experience, the more nephrons I put on, the more glazed eyes I see, so I didn't put it here. But you remember, the proximal tubule reabsorbs sodium when renin angiotensin is high. That is why you get a low urine sodium in situations of cardiorenal syndrome where the tubules are still functioning. If tubular flow or urine flow is not getting to the loop of Henle, the collecting duct, distal convoluted tubule, you're not diluting. And hyponatremia is a free water problem. So you're not diluting, you are approximately reabsorbing all your sodium, so you're getting puffy, just like your heart failure patients are, but you're not diluting at the same time. You drink water, your sodium will drop. So this is kind of the progression you see when you have venous congestion, why you get hypervolemic hyponatremia. If this high RAS state is sustained, you will eventually get a functional perirenal AKI, your creatinine will rise, and then if that lasts long enough, you'll get parenchymal AKI. So this is the progression that I had in my head for hyponatremia to AKI. So I thought if portal vein works for venous congestion related AKI, it has to work for hyponatremia. So what we're normally taught in terms of like breaking up hyponatremia is this first 4 boxes, right? Have you guys seen this before? So hyponatremia is hypovolemic, euvolemic, hypervolemic. So let's break it down a little bit more. My 2 points of interest are going to be hypovolemic and hypervolemic in this lecture. They're both what you call a low effective circulating volume state. For some evolutionary reason, and I find this fascinating, is that when you are low volume, you have a weak pump, or you have very low vascular resistance, your baroreceptors interpret that exactly the same. Renin, angiotensin, aldosterone, ADH rises. So it's a very similar interpretation by the body, but it's a different endpoint. This side, you're swollen, but you also have high ADH, high RAS, low urine sodium. And on this side, you'll have low effective circulating volume, same thing, your urine sodium will look exactly the same. So this was all well and great, but it's very hard to differentiate this and this. I don't have the ability to do that consistently. And the evidence actually supports this. Physical exam, chest x-ray, it's not a good predictor of whether you're going to be hypovolemic or hypervolemic hypertension. This is where portal vein comes in. And so when the portal vein is pulsatile, I just want to talk about what's actually happening in the microcirculature. And the only thing I really want to point out is if this is your glomerulus, you have your glomerular tuft, you have Bowman space. Filtration happens because the pressure here is higher than the pressure there. When you have venous congestion, your kidney swells. It usually correlates with intra-abdominal hypertension as well. So the pressure within the kidney and outside the kidney increases, the pressure in Bowman space will rise, and your GFR will drop. So volume overload venous congestion can cause AKI. Giving more fluid in this situation, as Phil kind of talked about earlier, can worsen this pre-renal physiology, can worsen this AKI. So let's talk about a case. So a lot of words on this slide. Main things I want to talk about. So the 54-year-old gentleman who was a cardiac arrest case, was PA arrest. Ross was detained after 20 minutes. They brought him in. He looked cold, clammy. He was on a little bit of levophed, intubated, sedated. It's a sodium talk, so we're going to just focus on the sodium. The sodium was 115. The Pro and BP was elevated, and the urine sodium was less than 5. FeNO was very low. I did a portal vein on him. So this is a portal vein study. Normally the portal vein should be flat. Veins should not be pulsatile. This portal vein is severely pulsatile to the point where it's biphasic. When you have a biphasic pattern like this, you have severe end organ congestion. So liver and kidney congestion. So I thought, all right, slam dunk. This is hypervolemic hyponatremia. We diuresed the patient. We got him 3.5 liters negative, and our sodium was 131 and within 48 hours. So this was important because this is a patient post-arrest. I needed to kind of normalize the electrolytes to tell the family, like, look, for neuroprognostication to really happen, I've done everything else and the patient is not waking up and the neuroexam is still poor. So this gentleman did not do well neurologically in the end, but I needed the sodium to normalize to say that. This was the portal vein on day 3. So you see, it's still pulsatile. So this is not normal. There's pulsatility there, but it's no longer biphasic. The next case was a 95-year-old gentleman who had a history of heart failure. His doctor had gone up on his Lasix and metolazone recently. So when he came in, he had a worsening renal function. His sodium was 120. He was altered. The family was thinking about making him comfort care, which I think a palliative approach in this case would be great. But they called us to take a look at him. They heard we were doing this portal vein thing, and they wanted to see if we could help in this situation. So we did the portal vein on this patient. And again, it's biphasic. So when I see this, in my head, it's a slam dunk that this is end-organ congestion, venous congestion, leading to this hyponatremia. So I said to the family, all right, I get palliation is in his future, but let me see if we can try to improve his mental status by correcting his electrolytes, and maybe he can come home with you rather than just being in inpatient hospice. We got him 3.5 liters negative, and sodium went up from 120 to 136. His mental status improved, his dyspnea got a little bit better. Still went down the palliative route, but he went home with the family. Right? So it was a good outcome in this situation. And we were teetering when the patient was first seen. Is the patient dry or is the patient wet? Because the diuretic increased, the patient could be hypovolemic. But this is where portal vein really helped. This was his portal vein afterwards. So you see, this is a normal looking portal vein. There's minimal pulsatility. So this is the algorithm that we proposed. If you have hyponatremia, check your light. So this combination, when you have a low sodium and you have a low FeNA, it tells me a few things. One, if you have AKI, it's probably reversible because you have enough tubular function left to actually avidly retain sodium, right? So I tell you, all right, we caught it at the right time. We caught it in the earlier spectrum. Maybe if we remove fluid or give fluid in this situation, we can prevent AKI from happening or getting worse. I would do a portal vein after. If it's pulsatile, you have hypervolemic, non-pulsatile hypovolemic, diuresis, fluids. Simple algorithm. So conclusions, traditionally we have not been good at differentiating hypervolemic and hypovolemic hyponatremia, but I think this is one possible way to create a tiebreaker between the two, especially when you're not sure. There's a few future applications that, and Dr. Dudeau studied the post-CABG patients. We're doing a study looking at patients post 30 cc's per kg, this is our sepsis bolus, and we're just following these patients and seeing who develops AKI and who doesn't. Eventually, the hope is to try to predict people who will be harmed by the 30 cc's per kg and maybe prevent that 30 cc's per kg in the future. And I had my email up on the last one, but that's okay. I will make sure that my email is available, and please email me for references, questions. I'd love to answer them. Thank you.
Thank you very much. Any questions for Sharad? Okay, that was, go ahead.
Yeah, heart failure must dramatically change the volume versus congestion calculus, right? Your portovenous, like somebody with EF or RV failure changes these values. So as part of your assessment of this, you also look at the heart.
I do. So I do look at the heart. So I do a full echo on everybody, but the great thing about portal vein pulsatility, it's a very easy study to do. We've looked at our own reproducibility. 95% of the time we get the same values. It's very easy. To learn echo and get good at it takes a long time. And so what I'm saying is that I don't care what's going on proximally. Let me just look at the site of interest. And I can be blinded to everything else. I know that that organ is probably congested. So that would probably be my answer to that.
Okay, great, thanks.
Any other questions? That was great. Thanks very much.